When you're ready, Sandy.
Good to go. So yes, it is 7:01 my time. So looks like we've got a lot of participants. So we would like to take a moment and welcome everyone to a very special week. Thank you for joining us. This is, as we have been stating, this is Bloodless Medicine and Surgery Week. It's actually Bloodless Medicine and Surgery Month, 2025. And so we will be using this week to celebrate the special moments and highlight the hows and why. And so welcome everybody. This week, we also want to introduce May as Bloodless and Surgery Awareness Month. And just say that this is meant to raise awareness about BMS, or Bloodless Medicine and Surgery. This is a superior form of healthcare, and it is organized by Bloodless Medicine and Surgery Group. And this is out of Calabar University, Nigeria, in collaboration with the Bloodless Medicine and Surgery Society. We also are in collaboration with the Society of the Advancements of Patient Blood Management, which is SABM, SABM, and the Malaysian Society of Patient Blood Management, MyPBM. So welcome everyone. The theme of our Bloodless Medicine Surgery Week 2025 is Bloodless Care in Orthopedics and Trauma. Also, I would like to introduce my co-moderator today, which is Dr. Majid Rafai, Professor of Pathology and Laboratory Medicine and Associate Director, Transfusion Medicine, Blood Bank, University of Rochester Medical Center, Rochester, New York, USA. And he will be moderating with me today and introducing our first speaker. Do we want to take a moment and just let everyone know that, I'm sorry, Dr. Rafai, that for anyone who has sound if they want to mute themselves. We also have a chat option for anyone who wants to ask questions. We're welcoming the chat room. They can bring questions to the forum for us. I think you're muted.
Can you hear me, guys? Good morning.
Mhm.
Okay. Good morning, guys, and or good evening. Depends where you are, guys, and thank you for joining our PMSW meeting for this year. We're gonna have this meeting over the next 6 days, including today, from 8 to 11 on the Eastern Standard Time. So today we will listen to three interesting talks by seasoned clinicians. The first one's gonna be the keynote address on avoidance of blood transfusion in trauma, how and why. Then a talk on the challenges of iron deficiency anemia in orthopedics and trauma. And then we'll end with a talk on raising the hematocrit in orthopedics surgery without blood transfusion. Before we start this, I would like to invite our past president, Dr. Nathaniel Osoro, who's a general surgeon and the chairman of Bloodless Medicine and Surgery Group in University of Calabar in Calabar, Nigeria. Dr. Osoro.
Thank you very much, Dr. Efai. It is my privilege to welcome you all to the Bloodless Medicine and Surgery Week 2025. The month of May, as you heard, is the Bloodless Medicine and Surgery Awareness Month. And of course, it was initiated by the Bloodless Medicine and Surgery Society 2 years ago. That is the month of May as the Bloodless Medicine and Surgery Awareness Month. So in this month of May, the Bloodless Medicine and Surgery Week is a special week of webinars featuring high-quality scientific presentations that shed light on various aspects of bloodless care. This year, the focus is on bloodless care in orthopedics and trauma. Often people wonder how possible is it to carry out bloodless care in a setting of orthopedics and trauma. We're going to hear from some of the brightest minds in the medical world why we should consider bloodless care as the standard of care, even in emergencies, based on current scientific evidence. We will also learn how the experts raise the hematocrit, minimize blood loss, optimize tissue oxygenation, and support the patient's tolerance of anemia, the 4 pillars of bloodless surgery. Within the Bloodless Medicine and Surgery Week is the Bloodless Surgery Day, that is May 16th. And this is a day in honor of the pioneering efforts of the father of modern bloodless surgery, that is Dr. Denton Cooley, who on that day in 1962 carried out the very first bloodless open heart surgery, paving the way for bloodless surgery in various other subspecialties. The theme for this year's World Bloodless Surgery Day is Patient's Blood, the Best Blood. We have a world-renowned clinician and academician who is going to speak on that topic on Friday, on the World Bloodless Surgery Day. This year, we are also featuring a new slot on the World Bloodless Surgery Day, and that is Heroes of Bloodless Surgery, or you could say Heroes of Bloodless Medicine. Please listen to the #1 PBM podcast host in the world as she does justice to that topic in discussing one of the great unsung heroes of bloodless surgery. And by the way, do you have a hero of bloodless medicine and surgery that you know about? Please send us his or her name and the name of anyone you believe can speak on the subject. And we will be glad to feature your hero in future webinars. We are also going to listen to patients who have had bloodless care in orthopedics and trauma. So that will again be on Friday. And that discussion, the panel discussion, will be led by one of the great matriarchs of bloodless medicine and surgery. So please be there on Friday to listen to patients and their clinicians. We are very grateful to all the speakers who spent time, energy, and other resources to put together the talks at this week's webinars at no cost to us. The least we can do is to give them our full attention and try to put their teachings into practice in order to improve the clinical outcomes of our patients and protect patients' rights. Yes, it's about improving clinical outcomes alongside protecting patients' rights. We are also grateful to the organizers of this program within the Bloodless Medicine and Surgery Group, University of Calabar, the Bloodless Medicine and Surgery Society, BMSS, and the Society for Advancement of Patient Blood Management, SABM, and also the Malaysian Society of Patient Blood Management, MyPBM. Dr. Majed Refai, who introduced me, is the conference chair for the Bloodless Medicine and Surgery Society this year, 2025. And he is also on the SABM board, while Adrian Kozenewski is a BMSS conference co-chair and secretary. And we are very grateful to them and members of BMSS conference committee for their excellent organization and direction. We'll be hearing from the new BMSS president today. And while the SABM president and the MyPBM presidents will moderate some sessions within the week, we thank all moderators and panelists who are sacrificing their time and effort to ensure that the webinars run smoothly each day of the week. We thank you all in the audience, all attendees, and all who are behind the scenes helping to get this webinar going. We thank you all for joining the Bloodless Medicine and Surgery Week 2025, and we wish you an enjoyable and impactful academic experience. Thank you.
Thank you, Dr. Nathaniel Lesoro. We so appreciate your intro and your delivery and expressing all the hard work that went into making this happen this week. So at this time, we would like to invite our new BMSS president, or Bloodless Medicine and Surgery Society president, Mr. Christopher Samuto. He's a fellow of the Royal College of Surgeons of Ireland and the fellow of the Royal College of Surgeons of Edinburgh. And he will deliver his address to us. Thank you, Dr. Samuto.
Thank you very much. Bloodless Medicine and Surgery is an international multidisciplinary society of experts in blood transfusion avoidance. Founded in 2015, it is a unique medical society committed to improving clinical outcomes and protecting patient rights by promoting techniques of total avoidance of allogenic blood transfusion based on current scientific evidence. Blood transfusion is associated with adverse outcomes as well as hazards. Bloodless Medicine and Surgery Society promotes the science of providing quality healthcare to patients without the use of allogenic blood, with the aim of improving clinical outcomes and protecting patient rights. On behalf of the Bloodless Medicine and Surgical Society, I would like to welcome you all to the Bloodless Medicine and Surgery Week, starting today, 12th May, and ending on Saturday, 17th May, 2025. As has been said, the focus for this week is on bloodless care in orthopedics and trauma. The month of May is special to the bloodless family because May 16 is World Bloodless Day. On this day in 1962, Dr. Denton Cooley performed his first open heart surgery without blood transfusion, paving the way for more research in bloodless care, which has proved to be superior. During this week of webinars, there will be excellent presentations showing the evidence, the superiority, and effectiveness of bloodless care. Please find time to attend all the presentations if possible. I thank all the presenters for accepting to find time and present at this week's webinars, the moderators for accepting to be available for the smooth running of the webinars, and the technical team behind making this a reality. Please enjoy the week. I thank you all.
Great. Thank you, Dr. Smoto. So now we're going to start, guys, with our first keynote speaker. Before that, I would just like to remind you all of some housekeeping. So please hold any questions until the end of the presentations today. We have a questions and answer sessions, or you can also place your questions during the talk in the questions and answer chat as well. Please remember to minimize your chat during the talk as much as possible, just not to distract the other attendees or the speakers. The program is being streamed live on PMSS YouTube channel. In case anyone has difficulty with Zoom, you can definitely see it on YouTube channel. I think that's all of my the housekeeping that I would like to announce. Now we're gonna introduce our first speaker, Dr. Erin Soydam, she's gonna tell us about how to avoid the blood transfusion in trauma and why should we do that. So Dr. Soydam is a trauma and acute care critical care surgeon at Allegheny General Hospital in Pittsburgh, Pennsylvania since 2014. She attended medical school at the University of Pittsburgh School of Medicine and went to complete general surgery residency at the Medical College of Georgia in Augusta, Georgia. She completed a surgical critical care fellowship at the University of Hawaii and started her career at the Queens Medical Center in Honolulu, Hawaii, for a few years prior to returning home to Pittsburgh. She is the medical director for patient blood management and bloodless medicine for Allegheny Health Networks, which is about 14 hospital health system since 2016. She's newly elected to the Society of Advancement and Patients Blood Management, SABM, Board of Directors, and has participated in the SABM Annual Meeting Planning Committee from 2020 through 2023, as well as the SABM Membership Committee since 2021, presenting and moderating the annual meeting and submitting multiple abstracts with her surgical residents and patients blood management team. Dr. Soydam has also been a featured speaker for the annual meetings of the Bloodless Medicine and Surgery Society and the Asia Pacific Society for Patients Blood Management. Dr. Soydam's clinical research areas include massive hemorrhage management, management of coagulopathy, and optimization of anemia. She is an assistant professor in the Department of Surgery at Drexel University College of Medicine and is core faculty member of the General Surgery Residency and Surgical Critical Care Fellowship at Allegheny General Hospital. She also serves as the Medical Student Surgical Clerkship Co-Director for the Drexel University students rotating at Allegheny General Hospital as third-year medical students. With no further ado, Dr. Allegheny, please, the floor is all yours.
Thank you. Good morning. Thank you for the welcome. Let me pull up my slides here. All right, is that looking good to go? Okay, so we're going to talk about avoidance of blood transfusion and trauma today, how and why. And we're going to base our discussion on the 4 pillars of bloodless surgery, and then explore bloodless medicine techniques in patient care, the adverse effects of blood transfusion and trauma, and the improved outcomes that can be achieved with bloodless care. So many are familiar with the 4 pillars of the Bloodless Medicine and Surgical Society, which include optimizing the hematocrit, minimizing blood loss, optimizing tissue oxygenation, and lowering the transfusion trigger or tolerating anemia. So to start with the first pillar of optimizing the hematocrit, I'm going to talk a bit about stopping the bleed, correcting coagulopathy and platelet dysfunction, and managing acute blood loss anemia. Stop the bleed is actually the term that we use in the American College of Surgeons for a program designed to teach laypersons and emergency response persons some field techniques to stopping the bleeding and triaging folks in a similar any sort of mass casualty event or in any person who may be bleeding in the community. But it's a catchy term that helps remember or helps to remind us that we need to arrest bleeding early. And to do that, we need to be able to detect it and understand that this is an urgent situation where a patient needs immediate action. So the first step is to identify that a patient is significantly bleeding and requires early action. Some of the pre-hospital interventions that can be performed include avoiding excessive crystalloid fluids, which may lead to dilution of clotting factors and acidosis, which can worsen bleeding. Permissive hypotension, we talk about a patient who's awake and alert and able to interact with you is perfusing adequately. And so although their numbers or their blood pressure may be on the low side, if they're perfusing, we would allow that to prevent further head to the bleeding and worsen blood loss. Depending on the area of bleeding, if there's external bleeding that may be addressed with direct pressure, tourniquet use, or kaolin-based dressings such as QuikClot or similar dressings that may assist with arresting bleeding, those can be used in the field pre-hospital. And then prompt presentation to a trauma center, obviously as possible, depending on the location and the system of transferring patients, trying to get them somewhere where they can stop the bleed as soon as possible. And another adjunct is tranexamic acid or TXA to also help arrest bleeding. So as I said, it's most important, I think, to identify the patients that are in trouble and recognize hemorrhagic shock. And if we wait until patients are hypotensive, we're getting late to the game. We're recognizing shock a little bit late. So earlier signs of shock before hypotension may be patients who are cool, tachycardic, decreased capillary refill, starting to have altered mental status or signs of poor perfusion. And we know that once the patient shows signs of tachycardia, we're already in class 2 shock with 15 to 30% blood loss of the patient's total blood volume. By the time the patient exhibits hypotension, we're already to class 3 shock or 30 to 40% blood loss. So any efforts that can be made to identify shock before we get to that point will help us get ahead of the game. We also want to recognize that patients have coagulopathy and platelet dysfunction, all patients, even those that we would otherwise characterize as young and healthy and not consider possibly the effects of this on their bleeding. So we want to recognize that trauma itself causes coagulopathy. We have trauma-induced coagulopathy, which isn't perfectly understood, but is understood to be partly related to dysregulation of the protein C system. And 25 to 35% of injured patients will have trauma-induced coagulopathy. These patients will have poorer outcomes with increased length of stay in the ICU and the hospital, increased time on the ventilator, multi-organ dysfunction, and increased mortality. So again, we want to keep in mind that this is not an uncommon phenomenon and make sure that we're identifying it in our patients and intervening. Similarly, patients having traumatic brain injuries will exhibit coagulopathy up to a third of those patients, again, who may otherwise be young and healthy. So we want to be sure we're not missing that. And platelet impairment also occurs in the setting of trauma and injury. When patients are injured, they also have endothelial injury, which contributes to platelet impairment. This is quite common in up to 46% of patients on admission and 91% sometime during their hospital stay. So again, something to make sure that we're identifying and intervening on. And then, of course, some of our patients may be taking medications that inhibit their coagulation and platelet function for their medical problems. Other factors that contribute to coagulopathy include alcohol use, malnutrition, iron deficiency, hematologic disorders, and liver and kidney disease. And the mechanisms or things to consider in patients with kidney disease include uremia, which causes platelet dysfunction and bleeding, and deficient erythropoietin to help recover anemia and make new blood cells. So we think of the vicious triad of the three things we want to make sure we're avoiding to make sure that that's not contributing to worsened bleeding. So the vicious triad of uncontrolled bleeding includes coagulopathy, acidosis, and hypothermia. We'll talk more about coagulopathy in depth, but for acidosis, we want to consider that patients with tissue injury and hypotension develop acidosis, which is going to affect clotting with the effect of pH on enzymatic reactions. This can be worsened by normal saline, which causes a hyperchloremic acidosis. So in our choices, we may want to choose lactated ringers or alternative colloid fluids to normal saline that may contribute to acidosis. Hypothermia will also affect our clotting by the effect of temperature on clotting reactions. And so we want to be careful as we're exposing the patients to identify their injuries, that we're then warming them, making sure we're warming any fluid they're receiving. Hypothermia also contributes to platelet dysfunction. And at 33 degrees Celsius, we're already having deficient factor function up to 50%. So we want to keep our patients warm. To dive more into the coagulopathy and platelet dysfunction, particularly our patients that are on medications, we want to be thinking about how we can reverse those medications to prevent further bleeding. So for warfarin, depending on if your bloodless medicine patient accepts clotting factors, you could consider the use of prothrombin complex concentrate. All patients would accept vitamin K, which may help with reversal of warfarin, albeit a bit in a more slower fashion. Direct oral anticoagulants, such as apixaban and its relatives, have, in some cases, direct antidotes, including andexanet alpha and idarucimab or Praxbind, but these may not be available widely as they're relatively expensive. But we also, in our institution, use FIBA or a 3-factor clotting factor, if that's accepted by your patient, to reverse any direct oral anticoagulants. For antiplatelet agents such as aspirin or Plavix, we use desmopressin to help reverse the effects or ameliorate the effects of that. Most antiplatelet agents are not reversible, but we can stimulate platelet function with desmopressin or DDAVP. And in order to identify coagulopathy, as I mentioned, which is common in all of our patients, including those not taking any medications, we want to make sure that we're identifying what abnormalities in coagulopathy they may have. And the gold standard or best way to do that would be with viscoelastic testing, as opposed to more traditional measures of coagulation, which don't really show you the whole picture of how a patient's clotting. So viscoelastic testing would help us identify and characterize any abnormalities in clotting that we can then intervene upon. As far as desmopressin or DDAVP, this functions by increasing von Willebrand factor and stimulating platelet adhesion. A couple studies of note, one meta-analysis looking at desmopressin compared to placebo in the effects on bleeding showed that with desmopressin, transfusion requirements were reduced, as were blood loss and risk of reoperation. And there was not a significant difference in venous thromboembolism, which is sometimes a concern with the use of DDAVP, although the literature really bears out that this is not a very significant risk. One study that we performed at our institution looked at traumatic brain injury and platelet function to prevent further bleeding in the setting of intracranial hemorrhage. And we found that giving desmopressin alone reversed platelet dysfunction just as well as if you gave platelets as well. And so our practice is to avoid platelet transfusion and depend on desmopressin to help us reverse any platelet dysfunction and prevent further bleeding. Moving on to another tenet of minimizing blood loss. We're going to talk about controlling hemorrhage, correcting coagulopathy, and cell salvage. So again, controlling hemorrhage requires us to first identify it. We want to be sure that we're performing our trauma role in the organized fashion that it's designed. Here in the US, we use our ATLS protocol, or Advanced Trauma Life Support, which all of our providers undergo the training and the course regularly to keep up on our skills, make sure that we're organized in our approach to trauma patients. As we know, in the setting of injury and trauma, things can get a bit chaotic. There may be some panic or very extreme concerns. So one good way to kind of stave that off is to make sure that we're very organized. We're doing the same thing every time to approach our trauma patients, treat them in a systemic kind of organized fashion, and not miss any injuries. So we'll use our protocol with our primary surveys, our secondary surveys. We used our FAST exam or ultrasound exam in the trauma bay to quickly identify any internal bleeding. We're exposing our patients and rolling them in a log roll fashion to make sure that we're not missing any external bleeding. Of course, presuming that any shock or hypotension we see is hemorrhagic until proven otherwise. So looking for any source of that hemorrhage, either externally or internally. If their condition is stable enough to undergo imaging, usually we're relying heavily on CT scan to look for evidence of internal hemorrhage as well. But we want to be doing this all in a pretty quick fashion. And again, having an organized protocol, go through the same steps each time, kind of moves the patients through all those requirements to help us arrive at our diagnoses and plan our interventions. Once we identify that bleeding, we want to reduce blood loss efficiently and control that hemorrhage. So that may require a trip to the operating room. It may be interventional radiology that can help us with a minimally invasive way to stop bleeding, or especially bleeding that's difficult to address in the operating room, especially pelvic bleeding related to pelvic hemorrhage, pelvic fractures, or potentially hepatic bleeding. May be best served in interventional radiology, depending on the injury. Depending on the patient's hemodynamic status and whether they may tolerate pneumoperitoneum, we could consider a laparoscopic intervention to, again, do a minimally invasive technique to reduce blood loss. This is sometimes possible, but sometimes not, depending on the patient's hemodynamics and clinical state. When we're on the opposite end of patients that are in pretty serious trouble, we want to be considering damage control surgery, where our goal is not to fix everything and make everything beautiful the first time around. We're going to consider segmenting operations into several trips and focus the first time on stabilizing the patient. So controlling any contamination from any bowel injuries, controlling any bleeding with sutures, with resections, with packing, and then temporarily closing the abdomen and planning a return trip to the operating room at a later time when the patient's in a better state to tolerate an operation. So the goal is to control contamination, control bleeding, get the patient out of the operating room where they're warmer. We can resuscitate them more fully in the ICU and come back another day. Other things we can use in the operating room to help us control bleeding are our hemostatic agents. We have been developing a nice reference sheet that shows which hemostatic agents contain clotting factors or albumin to help identify which would be accepted by bloodless patients depending on their choices. So we're trying to have that at a ready reference for our providers to see what patients do and don't accept. And of course, we always use this term meticulous hemostasis as something that we focus on in our bloodless patients. That sounds like something that is certainly important to me or my family or any of my patients. So of course, we want meticulous hemostasis in all of our patients to avoid any excessive blood loss. Our next pillar discusses optimizing tissue oxygenation. So of course, we need to maximize oxygenation and reduce oxygen consumption. So maximize delivery, reduce consumption where we can. We all learned about that hemoglobin oxygen dissociation curve and the factors that shift it one way or another. So again, that comes into play the acidosis, the hypothermia that affects the way our hemoglobin releases oxygen to our tissues. And we want that to be on the right side of the curve to optimize oxygen delivery to our tissues. We need to have monitoring in place to help us determine if we're optimized, if there's how we're doing as far as keeping all those organ systems healthy. One, I think, seems to be one of the hotter topics in critical care is how we manage fluids, right? It used to be more is better, everyone got flooded, and we know that that's not going to treat our organs well, and a lot of them are not going to like too much fluid. So it's kind of finding that sweet spot of goal-directed fluid therapy to optimize that tissue oxygenation, oxygen delivery, and then find the sweet spot and try to stay there without excessive fluids, which may further insult our organs. Enhanced recovery after surgery or ARIS protocols are also usually a consistent topic that, again, focuses on kind of optimized fluid therapy and trying to get patients to nutrition as soon as possible to replace any fluids. And then another consideration may be hyperbaric oxygen therapy if we're really meeting our extremes of not being able to deliver oxygen. On the flip side, to reduce oxygen consumption in a setting where oxygen delivery is challenging, things that we want to make sure we're doing are preventing fever, whether we're cooling the patient with ice packs or those Arctic blankets, or if we have a cool guard or a catheter that can help control the temperature of the bloodstream. Any prevention of fever will help reduce oxygen consumption. Similarly, infections are going to make the job harder. So we're going to work on preventing and managing infections to reduce oxygen consumption. Sedation may be necessary and or paralysis to reduce oxygen consumption with any patients that are more awake or more agitated or uncomfortable from pain from their injuries or dysynchronous with a mechanical ventilator. Then we may be able to meet some of those challenges with improved sedation and or paralysis. And then taking over their breathing with a ventilator is sometimes required for the patient's care or to help reduce oxygen consumption. So that's another way to optimize is to optimize your ventilator management. And our last pillar is the lowering the transfusion trigger or tolerating anemia, which is, I think, in my view, largely a culture change to start considering the clinical picture of your patient and focusing on that rather than the knee-jerk reactions to hemoglobin is ... So just because it's a certain number, I have to do a certain thing. So one thing that we need to do is prevent iatrogenic anemia and then treat anemia with alternatives to transfusion. We need to recognize anemia as its own diagnosis and own item on the problem list that needs to be addressed. I think it's such a common problem in folks that have any trauma or surgical intervention or any blood loss, whether it's just from lab draws in the hospital. Most of our patients have some degree of anemia, and we need to make sure that we're managing it proactively and not just considering it a byproduct of having surgery or being injured or being in the hospital. So acute blood loss anemia, a lot is preventable in the hospital or inpatient setting by eliminating unnecessary blood draws. So we do much better with this in our bloodless patients, but this would benefit all of our patients to avoid any unnecessary blood draws. When you're having those daily labs and every day they're the same, plus the patient is in an inpatient setting being monitored very closely by clinicians, we can use other clinical acumen to decide how our patient's doing, or if we really need lab draws to help us guide our clinical management, as opposed to those kind of rote daily orders that don't get looked at very closely. We can use low-fill tubes or pediatric tubes for our lab draws to minimize iatrogenic anemia. Point-of-care labs may give you a lot of information with a lot less blood. For example, an ABG will tell you about your patient's acid-base status, oxygenation, ventilation, hemoglobin, with one test as opposed to multiple separate tests and lab draws. We can use non-invasive hemoglobin monitoring to trend patients' anemia. And depending on the setup, if they have a central line or an arterial line, they may be able to have their draw waste returned to them to prevent blood loss. We need to help our patients make new blood for the blood that they've lost, which we know is going to be more challenging in certain patients than others, depending on their degree of illness. But things that your bone marrow needs, the building blocks to make new blood, is erythropoietin, which may be augmented with a ESA or erythropoietin stimulating agent. And then your bone marrow needs iron and vitamin B12. I have forgotten folate. We also need folate. And to absorb iron enterally, we need vitamin C. So our institution's developed an anemia protocol, is kind of the term we call it. But basically, it's that list that I just showed of vitamins that are needed to stimulate bone marrow production. And it also helps to stimulate conversations and discussion about making sure that the patients are treated for their anemia, that we're preventing iatrogenic anemia, and that we're tolerating anemia and focusing more on our patient than the number. Our anemia protocol is within our electronic medical record. There's an order set that can be searched and brings up all of these doses automatically to make it easy just to click through, get the patient what they need without having to memorize all the doses or the kind of cocktail that we've got. So we can choose a form of iron, whether that's IV iron or oral iron, B12, vitamin C, and folate. And then to consider hematocrit, especially in our bloodless patients, in our renal failure patients, and remembering that hematocrit alone won't work unless you give the patient the other building blocks that are necessary for erythropoiesis. This is just an example I thought I would share of what our anemia protocol looks like. So when you open the order set, it's right here, and you can click through to get all of the components. We also have there an iron panel if you're considering giving IV iron to check the patient's iron to see if they're suitable candidates for IV iron, whether they're bloodless or not. I wanted to share with you some data from our institution. We looked at the effective use of this anemia protocol in our ICUs. In our main hospital here, we have 5 ICUs. that vary between medical patients, surgical patients, neurologic patients, cardiac patients. And we wanted to see how we were doing using the anemia protocol. You can see there that our anemic patients are significant. Up to 45% of the patients in our ICUs had significant anemia. But you can see in the last column there, our anemia protocol could definitely be used more. So especially ICU 3 has the most anemia and is using the protocol the least. So this is helping us guide our efforts of education of trying to intervene more for our anemic patients. And we found that just by using the anemia protocol, it correlated with fewer lab draws and fewer transfusions. And so it appears to be effective in reducing lab draws and transfusions and helping the patient's anemia with alternative treatment to transfusion and discharging them in better shape. We looked at just our one ICU where I work, where my team seems to be a little more influential on treating anemia and limiting lab draws. And we saw that in our ICU, the patients who were on anemia protocol, again, had fewer lab draws, higher mean hemoglobins, and fewer transfusions than the patients who did not get anemia protocol. Those were the statistically significant differences in our ICU. And we saw that over the years, this was really being uptaken. So we didn't treat most of our patients back in 2017. This data is needing to be updated with the more recent years, but you could see year over year, we were treating more of our anemic patients, and the protocol was kind of taking off. People were becoming more familiar with it, and it was becoming more of a routine in our clinical management to include anemia protocol in our patients. And that resulted in better hemoglobins in the anemia protocol group, which is the darker blue bar. It resulted in fewer blood draws. Again, the lower graph is the one of the patients who were on anemia protocol. We were drawing their blood less frequently, and they were getting less blood. So I think that also correlated with a tolerance of anemia, again, focusing on the patient, not the number. And as providers gain clinical experience and see that their patients do well without blood transfusions, that I think guides their clinical judgment and their practice patterns. And I think a key to this is to have anemia on the problem list. So as you're going through your patient's medical issues and the things that you need to address, their atrial fibrillation and their diabetes, anemia is right on that list of we need a plan for their anemia, just like we need a plan for the other problems that they are dealing with. Just to discuss a few bloodless medicine techniques, again, this is affected by the patient's preferences. If a bloodless patient accepts clotting factors or cell salvage, these are options to help us manage a patient through a trauma or a surgery. And then again, making sure that we're keeping the patient's blood in the body with less lab draws and iatrogenic anemia, and treating anemia. Some of the adjuncts or medications that we can use depending on patient's acceptance include those prothrombin complex concentrate, factor VIII inhibitor bypassing activity or FIBA, cryoprecipitate, which is the first factor that's depleted in a hemorrhaging patient. And so these are all options depending on the patient's preferences. Some medications that are more widely accepted and don't have to worry about containing clotting factors or albumin include the DDAVP, vitamin K, and tranexamic acid or TXA, which is part of all of our massive hemorrhage protocols, but particularly would be of use in a bloodless medicine patient. Cell salvage, if accepted, is something that I think we need to take more advantage of. Of course, this may be limited by your facility's capabilities, whether you have the equipment and the staff that's able to help you set up cell salvage in the operating room. Traditionally, it was thought to be used only if you expected more than 20% blood loss of the patient's blood volume. But I think it's important, if available to you, to use it in standby mode. If the patient doesn't need it, or if you don't collect enough blood to give to the patient, or if you have issues with contamination, you can consider the risks and benefits of giving the blood back to the patient. But if you don't collect the blood, then you don't have that option. So even using it in standby mode may help you in a patient who loses a good bit of blood and has less options by avoiding refusing or avoiding transfusion. There are very few absolute contraindications to cell salvage, which are basically anything that causes red cell lysis that will cause organ damage. And so you don't want to give blood back that's been lysed. That occurs with sterile water contamination, hydrogen peroxide in the field, any hypotonic solution. So you can use normal saline as your irrigant and avoid red cell lysis so that you can potentially give the blood back to the patient. Just a few notes on the why. So we know that adverse effects of blood transfusion are extensive. I think, the most common things that come to mind to providers may be taco or trolley that are not as common, but the most common effect is most likely immunomodulation and all of the things that happen by giving someone basically a transplant of someone else's blood. The effect is noted to be dose dependent. So one study that I've referred to in the first bullet point examined even single unit red blood cell transfusions. This was a cardiothoracic surgery trial that looked at patients that even received 1 unit of blood and the comparison between those patients and patients who were not transfused. And they did see higher mortality, stroke, ventilator days, renal failure, and reoperations than patients who got no blood. And you can imagine that the difference between 0 units and 1 unit is probably not significant as far as their hemoglobin or their perfusion. And so avoiding that 1 unit appears to really confer a benefit to the patients. And we also know that all of these adverse effects are dose dependent. So in patients who do accept blood transfusions, really minimizing the doses of blood to what is needed with no extra units is going to help patients avoid particularly infections. So the second bullet point refers to the PAMPER trial, which was a trial looking at pre-hospital plasma and the effect on hemorrhagic shock. And patients who received any red cells in that trial had a 2-fold increase in nosocomial infections, including pneumonia, bacteremia, catheter-associated urinary tract infections, skin and soft tissue infections, C. diff, etc. And so the number of red cells given was associated with the development of a nosocomial infection. So we know that limiting the dose is beneficial to our patients. And we know that patients who don't receive blood have improved outcomes. One not to be discounted factor, of course, is patient autonomy and the patient's participation in their healthcare and their decisions regarding their healthcare. We know that bloodless medicine care is effective and transfusion avoidance should be our standard of care and our best practice. We know, in the bulk of literature that shows restrictive versus liberal transfusion triggers, all of the outcomes are improved with restrictive, improved or equivalent with restrictive transfusion practices. So we know that patients who don't get transfusion do better. And they do better with lower mortality. And as far as healthcare administration standpoint, it costs less to take care of patients without blood. So we know that it's healthy for our patients and for our health systems and hospital systems to focus our resources elsewhere. And that is all I have. I do have some time for questions and answers. I will need to step away at 9 o'clock, but I can also leave my computer on to come back and check the chat and the questions and answers within the chat.
Thank you, Dr. Saddam. Dr. Osoro, did you want to just save the questions and answers still and see if we can't fit them in for Dr. Saddam prior to her leaving, or would you like to take some questions now?
I would. Nathaniel, I'm not sure if he's.
I think between you and Sandy, Majed, you can
I would
decide.
say let's just take a few questions here, Sandy, just because Dr. Serdam has to leave, so she may not be able to join us at the end.
Yes, we
Because
don't want to miss her.
I do see a few questions in the thing.
So Dr. Saddam, I will take this moment while Dr. Rafai is looking at the questions to just say thank you so much for your wonderful address. We really appreciated you sharing the 4 pillars with us on the anemia, and that would be like optimizing the hematocrit, minimizing blood loss, optimizing tissue oxygenation, and lowering transfusion triggers. And also for thank you for sharing with us your anemia protocols and your massive hemorrhage protocol, the data you shared with us, also your treatments. You really did a nice job of highlighting the whys and hows as well, and we really appreciate that. So we want to thank you for that. And then we'll go ahead and if Dr. Rafai has
Yes.
taken a look at that,
Yes.
go ahead, Dr. Rafai.
Yeah, thank you, Sandy. Erin, one of the questions I think for you here is there an indication to measure anti-10A for those patients on the WAC?
There can be, particularly in a trauma situation, you may not be able to ascertain when the patient last took their medication. And so I know each drug is different. Some prolong the PT, so a PT may still tell you if that medication is active, or an anti-10A level, depending on how quickly your institution can get that back to you, may also let you know if that medication is still effective. But I think in the setting of hemorrhage and the knowledge that the patient takes one of those medications, the plan would be to reverse it if the patient accepts clotting factors. We use FIBA at our institution, or prothrombin complex concentrate, or if you have the antidote, Praxbind or andexanet alpha, that would be effective as well. We do have Praxbind, we don't have andexanet because of the prohibitive cost. But those would all be options. I think, again, in the setting of hemorrhagic shock and knowing that your patient takes a DOAC, the plan would be to err on the side of reversing the medication if you could.
Gotcha. And would you provide this right from the beginning during the massive bleeding, or would you delay it until you get the results back?
We would reverse it right away if the patient accepts those medications, and still obtain viscoelastic testing to see kind of how we're doing in our resuscitation of the patient, if there's any other medications or interventions that may help reverse any coagulopathy or platelet dysfunction.
Gotcha. Dr. Saddam, these are the only questions I have in the chat. I think, let me see if anything's been added. I don't see anyone for you directly. Dr. Nathaniel Osoro, there's a question on, can you please send the link for the YouTube, the PMS YouTube link, please, to everyone. So if you can comment on this, or if you can just type it in the chat, is okay. One more question, Dr. Saddam, I have for you. What do you think about the early usage of tranexamic acid? I mean, I know some centers, they even using it in the EMS before they even make it to the hospital. So what's your intake about that?
Yes, that's our practice as well. Our pre-hospital helicopters and ground transport often will give TXA before the patient arrives, which we agree with. If they haven't received it, we start it as soon as we identify massive hemorrhage. We generally, all of the crash trials discuss a loading dose and an infusion dose. Generally, we treat everyone with the loading dose. We usually reserve the infusion dose for patients that only exhibit lysis on their viscoelastic testing. So once we have that viscoelastic test, we can see if they require the second dose or the infusion dose, because we find that most patients don't. So that may, avoid any potential risk of clot by not giving them a dose they don't need. But the initial dose, certainly, that's our practice as well, to give TXA up front.
Gotcha. Good. Okay, so I got a few more questions here. We have to move on, but I'll give you just a few more questions. Someone said, I would like to read the paper on the anemia protocol. What is it called?
It is not published yet. We are working on publishing it. We have prepared the manuscript and are submitting it for publication. To be determined.
Gotcha. One more question is these answers, guys, will require more time, and we have to move on. But if you can briefly, Dr. Salem, give details of ICU resuscitation mentioned under damage control surgery.
Right. So I think getting the patient to the ICU when they're unstable after you've controlled contamination, controlled hemorrhage with packing and an open abdomen to get them to the ICU. Generally, it's easier to warm the patient. It's easier to obtain any lab values that you need to assess whether you're acidotic. You can resuscitate acidosis. So again, depending if you have a bloodless patient or a patient who accepts transfusion, that resuscitation is going to look different. But you're going to be getting your updated viscoelastic testing, see what you can do to correct any coagulopathy, platelet dysfunction, to prevent oozing and bleeding that is kind of coagulopathic and can't be controlled with suture in the operating room. You're going to be kind of organizing all your results. If you're able to get the patient to imaging, if you had to go directly to the operating room from the trauma bay because the patient was unstable, once you're able to control things and stabilize the patient, you can obtain your CT imaging, see what other injuries you may have that you haven't identified, such as intracranial hemorrhage or fractures that you couldn't appreciate with an exploratory laparotomy, to help you kind of get the big picture of how your patient's doing, and try to resuscitate them and optimize them before you go back to the operating room for more work.
Great. Thank you. I'll finish with this question. In trauma cases, is early erythropoietin administration advisable?
I think this is a topic of study. I know at SABM last year, there were quite a lot of talks that focused on giving IV iron kind of in the operating room if you hadn't been able to optimize anemia beforehand. And I think EPO may be another thing to consider early in patients who have a large insult or who are bloodless and don't accept transfusion, to try to get a head start on their anemia. But erythropoietin is going to be something that works on a slower scale than a patient who's having hemorrhagic shock at the time of their initial trauma. So I think it is important to consider early and to get on board, but I'm not sure how crucial the timing is given that the effect is slower. But I think, really considering that IV iron and erythropoietin early can help you get a head start on trying to help your patient's anemia recover. Especially, I think that when you're losing blood, you're losing iron. So patients that have massive hemorrhage are going to need IV iron. So giving it early on is, I don't see any drawback. And so I think, although it may work slowly, it'll definitely help in the long run.
Gotcha. Thank you very much, Dr. Salem. I'll finish with this, and appreciate your time. And if you can join us later on around 10:30, that would be great.
Thank you so much. I'll keep an eye on the chat and type in some answers as well.
Appreciate it. Thank you. Sandy, it's all yours now.
Thank you, Dr. Rafai, and thanks again, Dr. Saddam. So because of time, we're going to go ahead and move on and introduce our next speaker, and that would be Professor Vernon Lowe. And his talk is The Challenge of Iron Deficiency Anemia in Orthopedics and Trauma. I do want to take one moment and introduce him. It is such a privilege to have you with us today, by the way, Dr. Vernon Lowe. So Professor Lowe is an executive head of Department of Medicine and Faculty of Medicine and Health Sciences for Stellenbosch University in Tygerberg, Cape Town, South Africa. He was previously chair and head of the Division of Clinical Hematology, Department of Medicine, University of Cape Town, and the Groot Schuur Hospital. Before then, he was professor and head of the Department of Internal Medicine and the Faculty of Health Sciences at the University of the Free State in Bloemfontein, South Africa. His research focuses on patient blood management, transfusion medicine education, hematological malignancies, and HIV-related hematological disease. Professor Lowe has authored and co-authored more than 100 papers in peer-reviewed medical journals, with more than 300 poster and oral presentations at local, national, and international meetings. Professor Lowe is a member of the several professional societies, including American Society of Hematology, the ABB, and ISBT. He serves on the WHO Strategic Committee for Patient Blood Management, the Global Transfusion Forum Steering Committee and Education Subcommittee, the Global Standards Committee for Transfusion Medicine, and the International Collaborative for Transfusion Medicine Guidelines Committee. So without further ado, we're just going to introduce Dr. Lowe for avoidance of blood transfusion and trauma. The challenge of iron deficiency anemia in orthopedics and trauma.
Good afternoon, everybody, and thank you so much for the kind welcome. May I just confirm that everybody can see my screen and hear me?
Yes.
I see some nods. Well, first, thank you very much, Dr. Soro, for inviting me again. I was privileged to speak at this meeting a few years ago, and it's great to be back. Although this time I got a topic that I'd never spoken on before. I do speak on iron deficiency quite a lot, but I had to go and update my knowledge a little bit on the orthopedic side. So with my disclaimers, I would like to add the disclaimer that I'm not an orthopedic surgeon, but a hematologist and an internal medicine specialist. Nevertheless, these are my disclaimers, most of which are not commercial, and I'm not receiving any funding for this lecture today. So I'd like to take us through a few different perspectives on this particular problem. And I thought of starting with a quick reminder for those who may be new on what patient blood management is. And 3 years ago, when I spoke at this meeting, I introduced you to this dog that I called anemia. And anemia, unfortunately, is often managed like an abandoned dog in medicine. We don't prevent it. We don't diagnose it properly. We don't look for a cause of the anemia. We don't treat it properly and holistically. And this is one of the problems we're trying to address with patient blood management. Anemia, of course, affects more than 2 billion people around the world. I believe that's about the number of people in the Catholic Church, thinking of the new Pope that was just appointed. And you can see here that more than half of all anemia, everything that you see in green, is due to iron deficiency. So iron deficiency on its own is one of the leading contributors to the global burden of disease. And whereas 2 billion people are anemic, half of whom might be due to iron deficiency, there's probably another 2 billion that are iron deficient, but not yet anemic. And if you put all of this together, that's more people than are on Facebook, WhatsApp, and Instagram put together. Who are most affected? Especially people in sub-Saharan Africa and Southeast Asia. And you can see here, Southeast, Central, West Africa, all disproportionately affected. But that said, you can still see that across the world, even in so-called high-income countries, there is a very, very high prevalence of anemia, and all of the green would be related to iron deficiency. In surgery in general, it is no different. This is a study published in South Africa, the preoperative anemia and clinical outcomes in the South African Surgical Outcomes Study, where they looked at about 3,000 patients, centers around the whole of South Africa, and 47.8% of patients arriving at the hospital for surgery were already anemic when they arrived. And what they found was similar to what was seen in other studies, is that anemia is independently associated with mortality, 70% increased risk, critical care admission, 50% increased risk, and longer hospital stays. Now, even in this population, iron deficiency remains the most common cause. You can see a small percentage of patients might have folate or B12 deficiency or renal failure, but 84% of patients with surgery that have anemia have iron deficiency, either absolute or iron restriction related to the trauma, the inflammation, or the underlying chronic disease. Now, when we think about surgery, we could look at it in this way, that in a perfect world, the patient would come with a preoperative hemoglobin that is completely normal, because the surgeons and the teams have optimized the hemoglobin preoperatively. Intraoperatively, no blood would be lost, all blood would be salvaged, and postoperatively, the patient will not be anemic and there will be no further blood loss and all blood will be salvaged. Unfortunately, in the real world, we know that is not true. Preoperatively, anemia is very common. Intraoperatively, we lose a lot of blood, and post-op, it's even lower. And the traditional paradigm used in many places in the world was to respond to each of these points, or each of these time points, by giving the patient a blood transfusion. And for that reason, especially those who come from the transfusion side of things, noted that surgery used about 50% of the world's blood supply. Now, this led to an initial historical response of saying, well, transfusion is, or blood is a precious gift, and we should use less blood. And there was a strong focus on blood conservation, focusing very much on the product rather than the patient. And yes, restrictive blood transfusion strategies with these threshold cutoff values of 7 versus 9 or 10 was very effective. It led to decreased mortality, improvements in rebleeding, acute coronary syndromes, and infections. But that was a very much product-focused approach, and it gave some clues that maybe blood transfusion on its own might be contributing to the problems. And this is in part where patient blood management has its origin, saying you as the patient come with a built-in factory of blood. So why don't we focus on optimizing the working of that factory? In other words, optimizing production of red blood cells. Do what we can during surgery to minimize bleeding and blood loss. And once you are out of the theater, optimize your ability to tolerate whatever anemia you might be left with. And this is where patient blood management, now defined as a patient-centered, not product-centered, patient-centered, systematic, evidence-based approach to improve outcomes of the patient by managing and preserving a patient's own blood, because we saw outcomes are better if less blood is used, but we now know that outcomes can be even better if we focus on doing all these other patient blood management related things. And this is therefore a concept not centered on a specific pathology or per procedure, not a specific discipline or sector of medicine. It's at managing the patient's blood, whereas blood conservation was very much focused on managing the blood donor's blood. And it is aimed at shifting attention away from the blood component to the patient with these measures. So what do we want to do? We want to maximize the patient's own resource, keep what they have and make the best of it. Now, we have to think about the landscape that we are dealing with. Why are we doing this? As we said, pre-op anemia is very common across surgeries, including, as you can see here, orthopedic surgery. In patients undergoing major surgery, 40 to 50% will arrive at the hospital anemic, but post-operatively, about 90% will end up being anemic. And the challenge is that pre-op anemia is now known to be associated with an increased risk of requiring blood transfusion, no surprise there, but also morbidity, mortality, more hospital readmissions, and longer hospital stays. And in this meta-analysis, looking at the association between preoperative anemia and mortality after surgery, almost 1 million patients in 24 studies, 39% were anemic. You can see that anemia was associated with a 3-fold increase in perioperative mortality, almost 4-fold increase of acute kidney injury, doubling of infections, increase in strokes, 5-fold increase in needing a red cell transfusion. Nothing of that sounds good to me. Beyond that, we now recognize that it's not just the anemia, but also the level and probably rate of blood loss and bleeding, as well as receiving a transfusion, that together, but also independently, are factors for an adverse outcome. So we need to always consider all of these. We want to limit transfusions, we want to limit blood loss, and we want to optimize patients' hemoglobin. Now, let's just use one example of intraoperative transfusion. We can see here, it's not just about the patient who receives a massive transfusion or 4 or 5 blood units. From the very first unit the patient receives, there's a significant increase in mortality, morbidity, pneumonia, septic shock, and infection. And when you go to 2 units, all of those numbers increase. And here you can see if you increase the number of transfusions further, the morbidity and mortality start to rise exponentially. So what about iron deficiency specifically in orthopedic surgery and trauma? And I noticed on the program that my colleague was going to speak about trauma, so I focused more on orthopedic surgery, although taking into account that much of the orthopedic surgeries relate to patients who have had trauma. Now, to understand why we do what we do, we have to understand a little bit more about iron metabolism, my favorite topic, but I have to shorten it today just to raise a few key points. So just to take you through this picture quickly. So firstly, iron comes into the gut on the, you can see the green part of the screen here. Let me see if I can just move this out of the way. There we go. You can see the green is the gut. Iron is taken up through the enterocytes. They load it onto these transferrin 2-seater canoes, as I like to think of them. The iron is then delivered to the bone marrow to be incorporated into heme and hemoglobin in the red blood cells, and then enters in the red blood cell the circulation. But what I want you to notice here is that only 65% of the body's iron is found in the red blood cells. Where is the rest of the iron, or where does the rest of the iron go to? So the important message that I want you to recognize here is that iron is needed in every single organ, in every single cell in the body. You need it to produce ATP in mitochondria, neurotransmitters in the brain, myoglobin in muscles. The development of the fetal brain is one of my favorite topics to speak on. But basically, you need iron everywhere. Also in bones, in wound healing, etc. So just on a mitochondrial level, for example, you can see that this is the molecular process by which ATP, your major energy molecule, is made. ATP is what powers your cells in these, almost say, these little batteries, the mitochondria. But what you can see here at the bottom, if you look at these different complexes that are there that are part of the process of generating ATP, all of them require one or other form of iron. Therefore, iron deficiency, even in the absence of anemia, can lead to all kinds of symptoms and complications, and we call that non-anemic iron deficiency. So it's important to note here that using hemoglobin as a screening test for iron deficiency is a very bad idea, because iron deficiency anemia is really the very last phase of iron deficiency. So women tend to struggle disproportionately with all these many symptoms of iron deficiency, even if they are not anemic. And this is such an important message for doctors. And you can see in terms of percentages how common these symptoms are. I'm not going to go into all the different organs that are affected by iron deficiency. For the sake of this talk, I just want to show you this slide. And basically, it shows you that iron is required in every part of the immune system, which is thought to be the reason why iron deficient patients have many of the complications that I'm going to share with you now. But we could talk about iron and the bones, iron and osteoporosis, etc. But let's focus on what happens to people when they are iron deficient. So this is a meta-analysis of 40 studies, 3.5 million patients who went for primary total hip arthroplasty, hip replacement, meta-analysis of 40 studies. What did they find in this 3.5 million people? A significantly increased risk of periprosthetic joint infection if patients had iron deficiency anemia. This was a study that was published around the same time of that meta-analysis, but not included in the meta-analysis, 57,000 patients. I just want to show you a few things. So if we start with surgical site infections, you can see that the odds ratio was 1.48. So the risk of getting a surgical site infection was 50% increased in iron deficiency anemia patients. And on the right, you can see all the risk factors and whether they contributed significantly. And what you see in bold are all the ones that had a significant effect. There are maybe one or two that are not in bold. But I want you to look at the number. 1.48 is one of the highest. If we look at periprosthetic joint infection, so not the wound, but the actual very bad infection in the hip replacement, it was more than double in patients who had iron deficiency anemia. And if I can take you back to the table on the right, you can see that of all the risk factors for infection, many of which were significant, iron deficiency anemia was the one that was the most important risk factor of them all. This is a study of iron deficiency anemia looking at early post-operative surgical and medical complications, again following hip replacement. 98, almost 100,000 iron deficiency anemia patients and almost 400,000 controls. At 90 days, you can see the complication rate in patients who had iron deficiency anemia versus controlled was significantly increased for many factors: blood transfusion, low platelets, anemia, ileus, acute renal failure, UTIs, urinary tract infections, etc. But overall, 36% increased risk of having a complication. Now, surprisingly, 1 year down the line, you can see, again, significant increase in joint infection of the newly replaced hip, periprosthetic fractures, as well as total implant-related complications and aseptic loosening, all increased in the iron deficiency anemia cohort. Very important, I think, for many of us working in sub-Saharan Africa, is that there was also a significant cost differential, where patients who were iron deficiency anemia, probably in part related to the complications, had a much higher hospital costs and slightly different hospital length of stay. I think the people who were not iron deficient actually may have stayed a little bit longer, surprisingly, but it was only 2 hours in total. So, healthcare utilization, we see increased hospital readmission or admission rates. We see an increase in mortality and an increase in ER visits. What about the knees? We've now learned about the hips. This is a study of 106,000 total knee replacement revisions. Not nice surgery, I am told. And shockingly, the medical complications, just look at all the medical complications, kidney injury, pneumonia, respiratory failure, ileus, etc., even myocardial infarctions were all significantly increased in patients with iron deficiency anemia compared to those without. And overall, the odds ratio for having a medical complication was 5-fold greater if a patient had iron deficiency anemia. Again, the cost was higher both on the day of surgery and 90 days post-operatively for iron deficiency patients. What about shoulders? Again, and I want you to see the pattern here. It's not about the joint. It seems to be about the iron deficiency anemia. So in terms of medical complications of patients with shoulder replacements, all the complications were off, well, except for pulmonary embolism in this particular study. Everything else, the risk was much greater. You can look at the odds ratio here, impressive odds ratios for all medical complications in this group. Implant-related complications, more fractures, more infections, more loosening, more dislocation, total complications, 65% higher. Hospital length of stay, again, greater for iron deficiency anemia patients. What about the spine? We can see here surgical complications, any greater in the iron deficiency anemia patients, wound infections greater, blood transfusion greater, acute myocardial infarctions, almost significant, but 8 patients versus 2. But the small numbers probably led to this not being significant. And you can see that the number of patients that had to go, actually, no, that one is not that important. Let's pass that one. Okay, so how does this information help us to make treatment decision? Now, we need to understand a little bit more about iron homeostasis, because that's where the keys in terms of therapy lies. So iron homeostasis in the body depends on the control of iron absorption from the GIT, because there are very limited mechanisms for iron excretion, and also getting iron out of the storage sites and the areas of recycling. So the key, we say, is hepcidin, and that little star there, I want you to remember, this will represent hepcidin in the subsequent slides. And you can see iron coming in at the top in the gut. It goes into the enterocyte and then enters the circulation through this iron door called ferroportin. Now that door can be locked with a key called hepcidin. And once this door is locked, no iron can actually enter the circulation and become available for red blood cell production. So whenever hepcidin production is high, ferroportin will be locked and iron absorption will be low. But when hepcidin production is low, the doors will be open and the absorption will be increased. So what does this mean? In patients with simple iron deficiency, no infection, no inflammation, no other chronic medical problems, the hepcidin levels will be low and the doors will be open. And you can see these doors are on the enterocyte, on the liver where the storage of iron happens, on the macrophages in the bone marrow and the spleen where the recycling takes place. So iron is easily available from all sites. So these patients can be treated with oral iron. They should be able to easily absorb it. So oral iron is very good in simple iron deficiency, but the problem is that's only about 6% of our surgical population. Most of our surgical patients have iron restriction due to anemia of inflammation or chronic disease, and for them you may need a different approach. Also, oral iron will only work if you give it enough time. You usually would need 6 weeks or more. If it is well absorbed, if it is well tolerated and the patients actually take their medication, and if it is enough to compensate for ongoing blood loss. Now, in a patient who's got infection, inflammation, cancer, chronic renal failure, even obesity or chronic allergies, hepcidin will be high and block iron absorption. But not only that, it will also block the removal of iron from the stores in the liver, from the recycling areas in the macrophages, and for that reason, patients tend to develop anemia of chronic disease, not because they don't have iron somewhere, but because the iron is not available easily. So in these cases, oral iron absorption will be blocked and it can't be used. And this is where one will have to consider either an intravenous form of iron or iron that can bypass the hepcidin blockage if you take it orally. Right. So what about IV iron versus placebo to, for example, reduce blood transfusion in patients with hip fracture surgery? So this is a meta-analysis of randomized controlled trials. And you can see here that although there is a trend favoring intravenous iron, it was not found to be significant. But the problem, of course, is if you go first look at the numbers, very small numbers, all the studies put together, only 400 and something patients in each group. Furthermore, the way in which patients were treated were not consistent. 2 of the studies used high dose iron, which is the typical dose we would use nowadays. 3 studies used 3 low doses of iron, which is probably insufficient. And some gave iron on admission, while others only gave it perioperatively. So once again, a very different way of doing things. So this leaves us with questions about dosing, timing, and there is a trial ongoing at the moment, the POP-I trial, where patients are randomized to intravenous iron with or without erythropoietin or placebo. And this is specifically focused now on the post-operative period. But just to see or to remember that the treatment of iron deficiency is only one part of a larger patient blood management program. But when we do want to use it, and I think we should use it and can use it, you need to think about time. How much time do I need to optimize the hemoglobin to make a difference really with my intravenous iron? So yes, some studies have shown that even giving IV iron together with vitamin B12, folate, and erythropoietin on the day before surgery can make a difference post-operatively. The ideal would be to give it long enough in advance to maximize the hemoglobin at the time and date of surgery. And I want you to just consider how long it could take, depending also on how fast your inbuilt factory can do something. So a patient who starts with a hemoglobin of 12, who you want to get to a hemoglobin of 13, that can happen within a week to a week and a half. But if the starting hemoglobin is 7, you are going to require 9 weeks to get the patient to target. So one has to, as a doctor, also think about these sort of timelines, especially in patients with elective surgery, where you really should optimize your anemia beforehand. But in most cases, within 6 to 8 weeks, you should be able to restore the hemoglobin in most people. So in practice, preoperatively, one would ideally evaluate the patient 6 weeks before, allow enough time to diagnose, classify, and treat. And if you are really there long in advance, you could still give oral iron. But if you do need to check the response and make sure the patient is tolerating it and it is working. This is a study literally just published. It's still in this format, not even in the final format yet, where they looked at iron supplementation preoperatively and whether it makes a difference in postoperative complications following lumbar-spinal fusion, 27,000 patients. Now, what was impressive is, firstly, before we look at the treatment, if you look at iron deficiency anemia versus no iron deficiency anemia, again, look at the complication rates, dramatically different for almost everything, including surgical complications and medical. If we look at complications in patients who received iron supplementation, in this case oral, versus those who did not, I was actually surprised to see how big a positive effect even oral supplementation had on outcomes, with those who received supplementation doing much better compared to the controls. Now, we speak about all of this, and I want to just say a few things about maybe another part of patient blood management. And I'm not going to say a lot because Dr. Saidam actually dealt with this in more detail. But iron deficiency anemia management does not stand in isolation. We need to think of other things. We need to think about what medication is the patient on, but also what supplements. If you Google Stanford medications bleeding, you will get this link or this document free of charge online. It's beautiful. It's a nice checklist, but I want you to see all the herbs and vitamins on the right that can lead to increased bleeding, which people don't often appreciate. But tranexamic acid, what a wonderful adjunct that we can use. Dr. Seider mentioned the CRASH-2 trial used in adult trauma patient, which led to, in 20,000 patients, an actual decrease in mortality and a decrease in death from bleeding, especially if used early, within 3 hours in patients with trauma, and no increased risk in surgical patients of thrombosis. And this is something very many people are concerned about. And I thought I'm just going to throw in a few things related to the safety of tranexamic acid in joint replacement. And this is a meta-analysis, and you can see here the risk of venous thromboembolism after total hip replacement using intravenous tranexamic acid versus control. No difference of embolism or thrombosis. This is when you use it topically, which is often it's injected, it's diluted in some saline, put into the joint. No difference in thrombosis. What about knee? That was hip. Knee arthroplasty, intravenous, no difference. Topical, no difference. Oral, no difference in thrombosis and pulmonary embolism. So I think we can be less afraid of tranexamic acid. And why do I also mention it? What about the combination of intravenous iron with tranexamic acid? And this is where the wonderful study by Professor Sigismund Lasocki, the new president of NATA, looked at IV iron and tranexamic acid combined or alone for reducing blood transfusion in patients with hip fracture. And you can see a multi-center 2x2 factorial randomized double-blind controlled trial. But just to show you, at the end of the day, the combination, that's the purple line at the bottom, halved the patient's need for blood and had a dramatic impact, whereas any of the different ones, either tranexamic acid or IV iron on their own, did not make a significant difference compared to placebo. So you really using patient blood management as a package deal is what we would like to do. And you can see here, among patients on double placebo, 30% were transfused versus 15% of those who got IV iron and tranexamic acids, and overall reducing blood transfusion by 50%. Post-operatively, not that much data. We were waiting for that POP-I trial, but you can see here people have tried post-op oral, but using it without looking at whether patients have iron deficiency or anemia, in those patients, it doesn't work. You use it in patients who actually have a problem. Otherwise, you won't see an effect. We know from many other surgical studies, major surgery studies, that iron post-operatively will improve hemoglobin concentration, decrease the need of blood, decrease length of hospital stay, decrease your occurrence of infection, and can improve quality of life. So in practice, it's never too early or too late, but as early as possible would be ideal. But even perioperatively, you can use it short term, and post-operatively, we're still learning, but extrapolating from other major surgery, it probably has a very useful place there as well. So I'm going to close. In summary, preoperatively, if it's elective surgery, try and delay surgery to optimize the anemia. If cost is not an issue, intravenous iron is very safe. And the only reason to not use IV iron, in my experience, is if there's a specific contraindication or if cost is a major issue. Peri-op or post-op oral iron is probably unlikely to work, and you will probably need intravenous iron. In patients with inflammation, cancer, or any other high hepcidin states, oral iron is unlikely to work well. You're going to need IV iron. Transfusion should be avoided as far as possible, and when used, limited to patients with severe symptomatic anemia where there's not enough time to prevent loss of life or limb by treating the underlying cause, patients with significant active bleeding, or that are hemodynamically unstable. And finally, I want to remind us all that iron deficiency, whether there's anemia or not, have many effects beyond anemia that can lead to symptoms and complications that might be completely unrelated to the anemia itself. Also, it is never a final diagnosis. Anemia or iron deficiency is not a final diagnosis. One must always think about the underlying cause, which could potentially be reversible, which could potentially be life-threatening. These are many of the people that work with us in South Africa on patient blood management, and I'm very grateful for their wonderful support. And with that, I guess the questions will be for later. Thank you so much for your attention.
Thank you, Dr. Lowe. And yes, I mean, if you can still joining us until later, we'll hold the questions until the end. For all the other attendees, please just post your questions in the question and answer. If you don't mind, please just start your question with who are you sending the question to? Like just type the name, Dr. Lowe, whatever, just so it will be easy for us to identify who should we ask the question. So our next speaker is Dr. Ofonaim Isai. And so the topic he's going to be talking about is raising the hematocrit in orthopedic surgery without blood transfusion. Dr. Ofonaim Isai is a laboratory physician and a fellow of a National Postgraduate Medical College of Nigeria. She's a consultant hematologist in University of Calabar Teaching Hospital in Calabar, Nigeria. Her area of expertise is anemia management and sickle cell disease, in which she has published in local and international journals. Dr. Isai is also a member of the National Cancer Technical Group in Nigeria. She is a sub-investigator to the GBT clinical trials and was a co-investigator to the 54 genes research. She is ISO 18159 certified and Washington University Monitoring and Evaluation and Project Management certified. Dr. Asine is a member of several professional societies, including the College of Nigeria Pathologists and the Bloodless Medicine and Surgery Society. She is presently working on improving clinical outcomes of patients through the use of transfusion alternatives. Dr. Asine, the floor is all yours, please.
Thank you so much. I'm grateful to be here. I want to thank Dr. Soro for the privilege to present once again. I did that some years ago, and I'm grateful to be here. I think the first and the second speaker has made my work a lot easier, on my presentation to be easy. So I'm talking on raising the hematocrit in orthopedic surgery without blood transfusion. So is my slide up? I'm not sure the slide is up. Okay, it's coming up. Thank you. We're talking on raising the hematocrit in orthopedic surgery without blood transfusion. I have no disclosure. Next slide, please. So I have no disclosure. Next slide, please. So these are my learning objectives: to identify the causes and significance of perioperative anemia, outline the problems of blood transfusions, describe the rational way of raising the hematocrit level. Next slide, please. So in orthopedic and trauma surgery, procedures require significant blood loss and can cause post-operative anemia, which in many cases can lead to allogenic blood transfusion. Due to the clinical, the economic, the logistic, and even the side effects of allogenic blood transfusion, it has prompted the patient blood management group to come up with modalities to reduce or eliminate the need for allogenic blood transfusion and also to improve the clinical outcome of these patients. Next slide, please. According to the World Health Organization, perioperative anemia is present in a good number of orthopedic and trauma patients, and up to 30% present with suboptimal hemoglobin level of less than 13 grams per DL. The preoperative anemia is shown to have an independent factor to increase the morbidity and mortality, and also prolong hospital stay in this patient, along with the risk of the allogenic blood transfusion. So it's imperative that we prevent preoperative anemia before a patient is taken in for surgery. Next slide, please. So patients scheduled for major orthopedic or trauma surgery should be checked for preoperative anemia at least 30 days prior to surgery. And this is to also help to make a differential diagnosis, as the second speaker has said. Is it iron deficiency that is causing the anemia? Is anemia as a result of anemia or chronic disorder? You know, what is really causing this anemia? And for appropriate treatment to be instituted before surgery is undertaken. In order to achieve the optimal result, treatment should start at least 4 weeks prior to the surgery. That's a month before the surgery. Next slide. Anemia could be defined as a condition in which the number of red blood cells and subsequent their oxygen carrying capacity insufficient to meet the body physiological needs. This is WHO 2011. Anemia is also defined as a reduction in the hemoglobin level below the normal range for age, sex, and race. So it is estimated that nearly 1/3 of the world population suffers from anemia. This reflects the hematocrit or the hemoglobin concentration. And for the World Health Organization, anemia less than 13 grams per DL in male or less than 12 grams per DL in female is taken as anemia. Next slide, please. So to grade anemia in adults, we have the mild, the moderate, and severe based on the World Health classification. So these are the mild, the moderate, the severe. So severe for both is less than 8 grams per deciliter. Next, for both sex, next slide, please. So for For us to be able to treat anemia and also to be able to diagnose, you need to know what are the etiology that what can cause anemia in adults. So anemia may be as a result of blood loss, which the first speaker spoke about, trauma, phlebotomy, exogenous blood loss from bleeding for investigations. It could be as a result of decreased red blood cell production, that's what we call hyperproliferative anemia. And it could be due to malignancy, which causes a bone marrow suppression. It could be as a result of hematological disorder, also which like aplastic anemia. Anemia can also be as a result of hemolysis, what we see in sickle cell anemia, thalassemia, which is hyperproliferative anemia. And we also have some acquired and hereditary conditions that can lead to hemolysis, like hereditary spherocytosis, hereditary erythrocytosis, sickle cell anemia that I just talked about. However, iron is the most common cause of anemia. And in the general population and also in surgical patients, iron is the most common cause. Martins and Stanley made the impression that hospital-acquired anemia has been identified to be a danger of modern medical care. As we have said before, anemia increases the mortality and the morbidity in a patient and also worsens the clinical outcome of that patient. Next slide, please. So what are the significance of perioperative anemia? Anemia in surgical patients is higher than in the general population. So in a general population, it's estimated by the World Health Organization that 32.9% are anemic, while in the surgical population, we have some 5% by Sander et al. As being anemia in a study that was done. And I've said before that anemia is an independent risk factor for morbidity and mortality in hospitalized patients. Even mild anemia, as low as 10 to 12 grams per DL in women or 10 to 13 grams in men, is a major, that is an independent risk factor. So it can increase the mortality by 41% and increases the morbidity by 31%. Next slide, please. Anemia also increases the risk of transfusion in patients. So we have to be, since we are trying to avoid transfusing the patient in surgical patients, and when you transfuse, it worsens the outcome of this patient's clinical outcome and prolong the hospital stay. So we are trying to avoid transfusion as much as possible. So how do you make a diagnosis of anemia? So the first step of laboratory diagnosis of anemia is to do a complete blood count. That's complete blood count is to do the full blood, the packed cell volume, the platelet. The red cell indices will give you an indication. Yeah, it's like a screening tool that can tell you, are you dealing with an iron deficiency? If the red cell indices are low, or are you dealing with an anemia or chronic disorder? So those are important in a resource limited area where you might not have to do other things like based on cost to do iron studies. So you can use the red cell indices to determine, are you dealing with anemia of chronic disorder or anemia of iron deficiency. Reticulocyte count is also important. It will help you to determine, are you dealing with a hyperproliferative anemia or a hyperproliferative anemia. The vitamin B12 assay, folic acid assay, that red cell folate assay are all important investigations that will be done. The iron studies, that the transferrin saturation, the serum ferritin, the serum iron, the total iron binding capacity are very important. And those are clear-cut things that you do that you can have the diagnosis. This is categorically iron deficiency anemia. Next slide, please. Even the early diagnosis and treatment of anemia, as has been said earlier, is critical to improve the outcome and to avoid transfusion in surgical patients. So you must investigate your patient early. You must begin to work up your patient for surgery early, not at the point of surgery. That's when investigations are being done. At that time, it may take a long time for the red cell to bring up. Next slide. So these are the pillars of patient blood management. As I've said before, all these complications of allogenic blood transfusion, the cost, the logistic, the adverse events, not just the cost, but the adverse events of it have led to the patient blood management being, the program being instituted. And we have 4 pillars: optimize the hematocrit, minimize the blood loss, support patient tolerance of the anemia. However, my topic is more on the optimizing the hematocrit. Next slide. As I said earlier, optimize the hematocrit, minimize blood loss, optimize tissue substitution, and support physiological tolerance of the anemia. Next slide. So to optimize the hematocrit, what do we do? Next slide, please. Before we go there, I think I want to just, I'm a hematologist, and I don't know, we kind of, people see us as people that wear red in terms of we transfuse, but you know, we're also wearing all of these adverse events of blood transfusion. So what, why don't we advocate for blood transfusion, especially in surgical patients? Because it's found out that increases the morbidity and mortality. Transfusion can lead to transfusion-related immune modulation, and that kind of causes a temporary immune suppression on this patient. And this is a patient that will prevent wound healing, so it can lead to infection, wound infection, which will also prevent the surgical site from healing properly. A patient that had malignancy and you are transfusing, by the time the patient develops this transfusion-related immune modulation, it can lead to cancer reoccurrence or even progression of that malignancy. And so it's not really advisable to do that. If we can avoid that, it's better we avoid that. There's transfusion-related acute lung injury. There's increased intensive care unit admission. As we said earlier, it also leads to prolonged hospital admission. There's increased length of stay of patients. Next slide. Studies have been done, and Andrew Bernard et al. Made a study that intraoperative transfusion of 1 or 2 units, that's 1 unit, you can say it's insignificant, but yet that 1 or 2 unit increases the morbidity, 30 days mortality of that patient. So you see the surgical wound site infection, there's pneumonia, there's sepsis in a general surgical patient. So just 1 unit, which we give and we think is nothing, can prolong that patient's stay up to 30 days in the hospital or more, and can lead to other complications of that surgery. Next slide, please. This is also showing that association of perioperative red blood cell transfusion and decreased long-term survival after a cardiac surgery. So if patient is transfused just 1 unit, it can lead to decreased long-term survival of that patient with just 1 unit because of the complication that is associated with blood transfusion, allogenic blood transfusion. Next slide. So as I said, in conclusion of the matter, is exposure to 1 or 2 units of red blood cell, it was associated from that study with 16% increase of hazard of decreased survival. So the decreased survival of that patient, if even 1 unit of the blood is transfused. So it's better you prep up your patient, optimize your patient before the surgery to avoid blood transfusion. Next slide. So surgical outcome and transfusion of minimal amount of blood in the operating room, that intraoperatively, is also not good because it also leads to prolonged hospital stay. Next slide. So what we have here in conclusion, is a dose-dependent adverse event. So even if it's 1 unit you are giving, as the study has said, it leads to 1.6%. So there's an increase in mortality. And the more units you give, the worse the prognosis of the patient. So just 1 unit of blood led to an increase in mortality. So if you give 2, if you give 3, you keep increasing the mortality of the patient, and the worse the outcome of that patient. Next slide. So how do we raise the hematocrit in a rational way, in a safe way? So concerns about adverse events of allogenic blood transfusion has prompted a review of transfusion practice with implementation of restrictive transfusion criteria. The criteria was initially 8 grams, it moved to 7, and it's coming lower. And right now, there's really no categorical number or figure to say this is the restricted. So people are trying to avoid transfusion as much as possible. So as now people come as low as 6 grams before they intervene with blood transfusion, and they search for safer and more biological rational treatments of anemia, such as the pharmacological treatment, in order to reduce patient risk and improve patient outcome. This was the British Journal of Anesthesia. So people are now tilting towards more pharmacological treatment methods than allogenic blood transfusion. And this is all to reduce the risk and improve patient outcome. Next slide. So the pharmacological treatment outcome of anemia is basically iron therapy with erythropoietin stimulating agent. So the iron therapy, we could have the oral iron therapy or the parenteral, which is intravenous iron therapy. The erythropoietin stimulating agent, we have the erythropoietin. Then we have the dabopoietin, which is a long-acting erythropoietin. We also have the erythropoietin receptor activator, that's the continuous erythropoietin receptor activator. These are long-acting erythropoietin. They can stay as long as 24 hours or more. So these are long-acting receptors of erythropoietin. Next slide. Oral ion therapy is preferred route because oral mechanism is the preferred route, but often impracticable for a surgical patient because some of them are not taking orally yet. So you have to wait for some time for them to take oral. 200 to 220 milligrams per day of elemental ion is the required ion. We have different formulations of the ion, oral ion. We have the sulfate, the gluconate, the fumarate, which are the common preparation that we have around here. But based on the elemental ion, the fumarate is preferable. So we have the vitamin C, which are the adjuncts that you can add, the folic acid, which must be added, the vitamin B12, the nutritional support. Patients must have nutritional support. Yes, we know we're in a resource limited, but we have the vegetables and the greens, so patients can make use of that and have nutritional support. Now, vitamin C helps with absorption, especially with the oral one. It helps with absorption. Dietary iron is inadequate to replenish iron stores. It's useful for prevention of anemia, but is however inadequate to replenish the iron stores. Next slide. So there's limitation of oral iron intake. So if there's inabsorption, unpredictable, the patient is not absorbing, it may require 2 to 3 months. That takes a longer time for you to replenish the iron stores, and patient may be intolerant to the iron. So absorption is inhibited by hepcidin, especially for patients that have anemia of chronic disorder or there's presence of inflammation. This can inhibit the absorption of iron. Is inadequate iron repletion is you must give iron with erythropoietin for you to have, like call it, optimized effect. Yes, so to optimize the effect, you must give iron with erythropoietin to have the desired effect that you want. Next slide, please. So intravenous iron therapy is faster, is safer, is effective, is a practical rule for the perioperative patients. You can or might not give it erythropoietin stimulating agent, but for optimal effect, it's better you give it erythropoietin stimulating agent. Now we have the you have to calculate the dosage that you give for the iron, and which this is the formula. Low molecular weight iron dextran. We have the iron dextran, the sucrose, the gluconate. These are ones that are given. However, sucrose is more preferable because iron dextran tends to have a hypersensitivity reaction, anaphylactic reaction that patients tend to have. So you administer this medication with normal saline in limited. First, you give a test dose to see if the patient will have any reaction. Then if the patient doesn't have reaction within 15 to 30 minutes, then you can now continue your medication. There are, however, newer preparation like fumarate, ferric maltase, and ferric carboxyl maltase. These are safe total infusion dose of up to 1,000 milligrams. That's for them, you can give a large amount of the dose at a time, and they are safe. Adjuvants can still be added like vitamin C, B12, and folic acid. Even if you are giving the intravenous medication, you still have to give the adjuvant to increase. These are things that the body needs, the red blood cell needs, the marrow needs, vitamin B12, folate to build up the red blood cell. Next slide, please. So as I've said earlier, poor absorption, poor tolerance, or insufficient time before surgery, and it is necessary for the use of intravenous iron. In most of the cases, medullary response for intravenous iron is between 1 to 2 weeks. However, for oral iron, you have between 2 to 6 weeks for the medullary response to be effective. So you see, intravenous iron is rapid to get a response from it. Next slide, please. So intravenous iron does not have a direct influence on the erythropoiesis. So its administration does not cause the supraphysiology hemoglobin level. That's increased hemoglobin level that people are afraid of, like polycythemia. So it does not lead to thromboembolism. That's what that statement is just trying to say. So the fear of thromboembolism with intravenous iron is out of it because it doesn't cause that supraphysiology hemoglobin. That's like polycythemia, that you're wondering that if your patient is going to have hyperviscosity and therefore will have thromboembolism. So it's not there. So it may even reduce the risk of thrombosis, because in iron deficiency, there's that thrombosis that you see in the peripheral blood film. So if you give intravenous iron, it can it will help the body to produce iron, and therefore the thrombosis is reduced. Next slide, please. So these are just the preparation for the iron, the administration, the minimum dose that you can give, and the dosing depending on which of the preparation that you are taking. So these are different things. Next slide. So limitation of intravenous iron therapy. Some tend to have anaphylactic, like I said, allergic reaction, especially with the iron dextran. They tend to have that, but iron sucrose and the newer preparation don't really have that. It's extremely rare in that. Intravenous iron also, there's concern of potential increasing the risk of infection. It's believed that when you give iron, it will increase the risk of infection. If the patient was already infection and it will now be overwhelming sepsis. Those are concerns that have not been proven. They are unproven hypotheses, even in clinical trials and other things, that if you give iron, it will increase the risk of infection. Intravenous iron has emerged to be safe and effective, and is an alternative for perioperative anemia management. So intravenous iron is quite safe. Next slide, please. So the erythropoiesis stimulating agent, as I've said, the erythropoietin is either alpha or beta. We have the long anti one, that's about double poietin. It increases up to 4 times the basal marrow red blood cell production. Erythropoietin acts on the late colony forming units, the burst forming unit, and the pronomoblast in the red blood cells. So that's where it has a receptor, and that's where it acts. So it increases the reticulocyte count by the 3rd day. Once you start the administration of erythropoietin, by the 3rd day, the reticulocyte count is increased. And by the 4th to 7th day, you start seeing an increased hemoglobin of at least 1 gram per DL every 4 to 7 days. So that's when you know that it's effective. As I said, the long-acting ones are the double poietin, which can be given up to 2 to 2.5 weekly, or up to 500 microgram every 3 weeks. Next slide, please. So for an orthopedic surgery, the dosing of erythropoietin is a little bit different, and there are 2 administration protocols. You can give under the 600 international unit per kilogram per week of the subcutaneous, starting 3 weeks before surgery, or 300 international unit per kilogram per body weight per day, starting 10 days before surgery. We continue on the day of the operation and 4 days following the surgery. So these are believed that these methods, this dosing increases the hematocrit at a rapid way, and also prevents patients from having allogenic blood transfusion. So both protocols achieve a significant reduction in the risks of allogenic blood transfusion. But however, from studies and research that I've done, there is no minimum effective dose for erythropoietin in order to achieve the targeted therapy. That's 14 grams per DL. It said it's not known, because some people can respond at a lower and some people can respond at a higher dose. Next slide, please. So Rachel et al. Observed that the majority of orthopedic and trauma surgery patients achieve this targeted hemoglobin with just 1 or 2 doses of the 4,000 international units of the recombinant hemoglobin, rather than having up to 4 doses that are recommended, and so therefore reducing the cost, because we have to think about cost in our own environment. So reducing the cost for that patient. Although the administration of the recombinant erythropoietin with oral iron significantly reduces transfusion requirement, but it is better administered with intravenous iron, as I've said earlier, and the desired, so it's better administered with intravenous iron. Next slide. So for caution for erythropoietin stimulating anemia. When you administer erythropoietin stimulating anemia, erythropoietin stimulating agent, it will optimize the pre-surgical red blood cell production and minimize erythropoietin stimulating induced iron deficiency. Now, so when you administer this, you must be careful, because it's believed you have to monitor the hemoglobin or the hematocrit Then a patient that has malignancy, it should be avoided if the hemoglobin is greater than 12 grams per DL. There's no need to give if a patient is greater, the hemoglobin is greater than 12 grams per DL. The patient is not receiving chemotherapy, there's still no need to give, you know. So some because chemotherapy, some of them are myelosuppressive, so they can reduce the red blood cell. So if you give that, there's no need to give when you are giving that. Next slide. So for contraindication for erythropoietin, protein is contraindicated in patients that have uncontrolled hypertension, a history of venous or arterial thromboembolism, patients who have no reason to, that cannot take appropriate antithrombotic prophylaxis. For whatever reason, the patient cannot take it, it's also contraindicated. If a patient has malignant hypertension, a history of DVT, or any of the thromboembolism, patient is not take erythropoietin. That is contraindicated in them. Next slide, please. So boosting red blood cell prior to surgery helps dramatically to cut transfusion rate. This was a program that was done in Ortho, and then we found out that. Next slide, please. So we found that when you boost the blood before surgery, that optimizes the hematocrit, it helps the patients and patients survive well. The drug Lance Armstrong used also help eliminate need for. There's supposed to be a transfusion wane, and it's supposed to be a drug. However, it's still neither here nor there. So it hasn't been gotten fully. Yeah, it's still on clinical trial that is believed to help to eliminate the need for blood during surgery. Next slide, please. So in conclusion, anemia is an independent risk factor for morbidity and mortality in surgical patients. This has been reiterated by all the speakers. Preoperative blood transfusion is associated with an increased morbidity and mortality. Anemia needs to be corrected promptly to improve patient surgical outcome. So it needs to be corrected. The diagnosis needs to be done. Treatment needs to be instituted and needs to be corrected. Pharmacological methods are safe. They are effective. They are rational ways to raising the hematocrit preoperatively. Intravenous iron erythropoietin effectively raises the hematocrit in surgical patients without the hazard of blood transfusion if instituted on time before the surgery. Next slide, please. So these are my acknowledgements: the Society for the Advancement of Patient Blood Management, Society for Thoracic Surgery, Patient Blood Management in Orthopedic Surgery, Bruce Price, MD, and Nathaniel Usoro. So these are my acknowledgements. Thank you very much. Thank you very much.
Thank you so much, Dr. Essine. We really appreciated your speech. And as far as how to prevent anemia, when to start prevention of before surgery, about a month before, 4 weeks, and treatment. So we really appreciated all of that. We're going to move on to the discussion Q&A at this time. And we do have a lot of questions, it looks like, in the chat. Dr. Rafai will also assist with that. Dr. Rafai, do you see anything in there, or do you want us to look into that? While we're doing that, I would like to introduce our panelists for today. That would be Dr. Jamila Sathar and then Dr. Kenneth Inaku. They're going to be joining, as well as the speakers that we had today, being Dr. Erin Saddam, if she is still with us, Professor Vernon Lowe, who also gave one of the keynote addresses today, and of course, Dr. Ofanim Essine, who we just had the honor to hear from. So, Dr. Rafai, do we have anything we'd like to address at this time?
Sure. Is Dr. Saddam back? Erin, are you there?
I know she mentioned she had to leave around 9, so we may have
I'm
lost
not
her.
sure. Yeah. Anyway, so I'll skip the answers that were addressed to her. One request from Dr. Lowe. Dr. Lowe, someone is asking, can I get the paper reference for Professor Lowe's presentation?
Yeah, I believe the presentations will be on YouTube, right? And I have added references
No,
to
I'm
each
sorry.
of my slides.
I'm sorry, those. Yeah, you're right. Yeah, they want all the references. Great. Thank you. Appreciate it. Okay. This question, I think it's also to you, Dr. Low. How to deal with unexplained refractory iron deficiency anemia for medical and orthopedic patients?
Right. Unexplained refractory. Let me just quickly see the question. Okay.
And yeah,
Yes. Okay. So when I look at that, one can divide that into two groups. You've got so-called IRIDA, which is iron refractory iron deficiency anemia, which is a congenital cause, very rare. And I'm not sure if this is what is being referred to, but just to say those patients typically have high hepcidin levels and mostly require intravenous iron, although there seems to be differences depending on whether it's mono or biallelic, the mutation, and there has been cases that responds to oral iron plus vitamin C, and there's also been cases, there's a theoretical probability that iron that is not absorbed in the normal fashion, i.e. via ferroportin, such as sucrosomal iron or endosomal iron might work in those patients, but we lack data. If we're talking about a patient that is not genetically compromised, but has got iron deficiency and they're not responding to treatment, I think one should go back to the basics and make sure that you have actually excluded an underlying bleeder. And don't forget that in all men and women that are postmenopausal, gastroscopy and colonoscopy, i.e. bidirectional endoscopy, is really important. And if that is normal, there might be further investigations required. So refer to your gastroenterologist, also gynecologist as necessary. But iron deficiency, if it's true iron deficiency and your diagnosis is accurate, it must have an underlying cause. If the patient is not responding, you must also think whether there are other concomitant deficiencies, B12, folate, vitamin D, and add those. Make sure that the patient's ingredients for the factory is 100% optimized. Don't leave anything out, but look for the cause. Sometimes the patient bleeds faster than what you can replace.
thank you. One more question is, beside the anemia management, how to deal with both anemic and as well as thrombocytopenic patients, since management of platelet deficiency is hard to strive on?
Look, it's a bit of a broad question, because whenever you've got an anemia, you have to determine the cause, and then you treat either the underlying cause, whether it's infection, inflammation, iron deficiency, B12, folate, or whatever. In terms of the thrombocytopenia, maybe I'm going to use my hematology hat and just say a few key points about thrombocytopenia. Many patients with thrombocytopenia actually have pseudo thrombocytopenia. In other words, they've got something called platelet clumping. Always, always ask for a peripheral blood smear, because there's many cases in the literature where patients died from treatment for thrombocytopenia, which was thought to be immune mediated or other causes. So they had splenectomies, and the end result was it was a simple pseudo thrombocytopenia or platelet clumping, which is an in vitro phenomenon. It's not in the body. It's in the test tube from the EDTA. If the thrombocytopenia is true, again, you always need a peripheral blood smear, because you want to, apart from clumping, also exclude fragmentation. And fragmentation hemolysis is life-threatening. It needs to be addressed immediately. Can be drug-induced, could be HIV-induced, have many causes. In terms of managing the thrombocytopenia, there's so many things that one can say. I mean, we can go on and on apart from looking for the cause, but I think one thing we've noticed is that people are often transfused unnecessarily. We've done a study, we've published it, where at least 50% of platelet transfusions in a large tertiary hospital were unnecessary, given for thrombocytopenic patients that didn't really need it. And maybe as a last comment, as part of the ICTMG, the International Collaborative for Transfusion Medicine Guidelines, we hope to have those new guidelines published soon. And all I will say is, I think we're going to have much less unnecessary platelet use once those guidelines are out.
Great, thank you. One more question. Let me go to a question to
Maybe just to
Dr.
say, there are a couple of questions that I've answered under answered. You'll see there for people who want to have a look at those. I've put the answers. I've typed in the answers already.
Okay, sure. Thank you. Dr. Afanang, a question for you is, the folic acid dose was given as 5 milligram on a daily basis instead of 5 microgram. If there are no kidney function comorbidity, is there any need to give EPO?
Okay. So sorry about that. I didn't get your question, please.
The question, if there are no kidney function comorbidity, is there any need to give EPO?
Yes, there is a need to give erythropoietin. Fine, there's no comorbidity, so the body is producing erythropoietin, but is it producing adequately at the amount that you want? Because already the patient is anemic, and so you want to increase the red blood cell, the production of the red blood cell. So you have to give something to the body to stimulate more production. What the body has is not adequate enough. What the body is producing is not adequate enough for the hemoglobin level that you want to achieve at the rate. So you have to give something else endogenously to stimulate the production of the red blood cell, irrespective of whether they have the kidney comorbidity or not.
Gotcha. Another question for you, Dr. Ofanang. Is there any need to restrict folic acid use in patients with leiomyoma being prepared for surgery?
Sorry, I didn't get that.
Is there any restriction to give folic acid for patients with leiomyoma before surgery?
Well, once you say patient has leiomyoma, it's not a benign condition. Sorry, it's not a malignant condition, it's a benign condition. So there's no restriction of giving folic acid, okay, except it was a malignant condition. Then you'd have thought of giving folinic acid. But gotcha, once it's leiomyoma, it is a benign condition. So there's no restriction of giving folic acid.
Great, perfect. One more question for you, Dr. Lu. I'm not sure if you answered this or not. I cannot tell from here. What is your experience regarding the timeline when erythropoietin is included in the treatment? Have you found that it shortened the response time? And do you have any estimates or expectation for time frame for response?
Yeah, so it certainly can respond timelines, can shorten timelines. And the thinking is that you could change a timeline of, you can probably half the time often when you add erythropoietin to your other treatments, keeping in mind the risks that might be involved, hypertension, thrombosis, if you overdo it. So one has to be careful. We don't have the luxury of using it routinely. It's too expensive. So in my setting, we limit it to patients who who don't accept blood transfusion.
I think those, Sandy, these are all the questions on the question and answers.
Okay. Thank you so much, Dr. Afai, Professor Lowe, and Dr. Essien. Dr. Sudam. We want to just take a moment also and thank the planning committee for everything they have done to kick off this week and to plan the next 5 days after today. So we really appreciate everybody's efforts and time and energy they have put into all the meticulous care of these addresses and speeches as well. So at this point, if we're okay, just want to introduce myself again. I am Sandy Mann. I'm one of the RNs and currently General Secretary for BMSS. Right now, I am in a triage position for Mercy Hospital Healthcare Systems out of Arkansas, USA. And the last 15 plus years, I have been involved with patient blood management, bloodless care, and with BMSS and also SABM. And right now, I'd just say it's an honor to represent such a good group focusing and dedicating themselves to bloodless care. So tomorrow, I'd like to introduce the program for Tuesday. We have 2 addresses that we would like to listen to, and the keynote address will start off with minimizing blood loss, the second pillar of bloodless orthopedic surgery, and that will be given by Dr. Stephen Frank, who is professor of anesthesiology, medical director, Center for Bloodless Medicine and Surgery at the Johns Hopkins Hospital in Baltimore, Maryland, USA. And then we will have bloodless spine surgery, techniques and benefits by Dr. Maud Hassam, who is Associate Professor of Surgery, Senior Consultant for Orthopedic and Spine Surgeon, Head of Advanced Trauma, UKM Medical Center, Kuala Lumpur, Malaysia. We will also follow that by discussion and Q&A, and then we will have some bloodless medicine surgery videos. Our moderators tomorrow will be Dr. Jonathan Waters and Dr. Mandy Yap. So we really look forward to tomorrow's session. These are highly educated and seasoned speakers that we will be listening to tomorrow. We really look forward to this program. So I will turn this back over to Dr. Rafai to close.
Okay, thanks everyone for joining today. We have a lot of people joined us today. I was able to see at some point numbers in a 240, which is great participation. I hope to see you again, guys, for the next 4 or 5 days. We still have until Saturday. If you can also try to join us on Friday, which is the Bloodless Day. That would be great as well. Thank you very much, and thank you for your questions. Again, another reminder, when you send the questions, please indicate which doctor you are asking, just so we can direct your questions to the right person. Nathaniel or Christopher, do you have anything to add?
Just to say thank you very much, Majed, Sandy, everyone, and to mention that after the session is over, we'll still try to be typing answers to the questions that were put in the Q&A in case we weren't able to finish all of them. So those who ask the questions can stay on, and we'll try and type the answers. But if we don't get to you, you can still ask those questions again tomorrow and in subsequent days, and we'll get to answer them. Chris?
Nothing much. I think it's been a great day. We look forward for tomorrow's meetings.
Great. Thank you, everyone.
Thank you.
Have a good day.
Thank you. Bye-bye.
Or good night. Take care.
Oh, yeah. In Malaysia, it's good night.
Are we staying on, Nathaniel?
Sorry, did you say something?
I was asking, are we staying on, or are we?
Yeah, stay on a bit. Let the panelists or some people try to answer some of the questions in the Q&A.
Okay.
The ones that are for other people, then we'll see about tomorrow and other days. So please
Live
just
stream.
give us about
Okay.
a few minutes.
The ones that we're leaving for tomorrow, we're able to just leave them in the Q&A chat. Is that correct?
So the Q&A chat won't be there, but the people that ask the questions can ask those questions again.
Okay.
In the new Q&A chat tomorrow.
Sounds good.
Continue live stream.
Yes, do that. Let me make sure do you need no